Lot, so get a snack for water. We don't exactly have healthy stuff, but I mean, we are talking about a healthcare topic, but it is what it is. I know. The other thing is too, we'll try to talk loud. We don't have any mics here. We're very grateful for Sebastian to let us use this community center. But we don't have some of the technology that would be more helpful for folks to hear us. My name is Frank Isley. I'm the executive director for the Indian River County Hospital District. Does anyone know what the Indian River County Hospital District is? Okay, a few people. So we've been around for over 65 years. Okay, and our goal as the Indian River County Hospital District, and we have a couple of our trustees here, which I'll acknowledge in a minute, but we focus on improving the health and well-being of all the residents in the county. So we survey the county, we look at trends that are happening nationally, locally, we look at access and affordability of healthcare services. And we make sure that all our residents, whether the number is 170,000, 175,000 now, I'm not sure what the most accurate number is, but just have access to affordable healthcare. Part of that is maternity. So that's the discussion we're having tonight. So we're talking about sustainability of maternity services. There's a couple of questions we're going to get to that are going to be the focus of the discussion. But we had this conversation last night in the south part of the county. We're having it up here and we're going to do it again tomorrow. And we're also having a countywide survey, which is underway right now, and they're wrapping that up. Our board of trustees wanted to make sure we hear from as many people as possible to get a sense of, number one, does our community want to have labor and delivery services? Number two, what's the community's thought on using tax dollars to help support some of the losses I'm going to talk about in a minute? So, does everyone know that Cleveland Clinic, Indian River Hospital, maybe just a show of hands, Cleveland Clinic, Indian River Hospital is the only hospital in our county that has labor and delivery services. Does everyone know that? Show of hands. Okay. Because, you know, I know most folks are familiar, you know, with Orlando Health being in our county now. However, they don't offer those services. Indian River Hospital is the only one that does. So one of the trends that we've been looking at in monitoring our trends, monitoring the healthcare trends is, you know, just the national closures, state closures, most recently Martin North. And the discussions we have with Cleveland, there's no immediate concern been voiced that there's going to be any closure of labor and delivery services. And I know having this discussion kind of makes people think, well, is this an imminent threat? Could this happen? You know, I've heard stories about, you know, concerns since this has been in the media. But the whole point of this is our trustees really wanted to get ahead of any potential closures that could happen with some of the losses being reported. So right now, Cleveland Clinic Indian River is reporting about 7.7 million in losses for the OBGYN service line. We contribute 4.2 to that already through our partners program, which we'll talk about a little bit later. And so the gap between the total loss and what the hospital district already contributes for partners. This is a program we started 30 something years ago, and the hospital district has been supporting in partnership with our hospital. That gap is 3.5 million. And that's what we're talking about tonight. So we've got some panelists with us tonight. We've got Mary Volsky, who's a long time, 26 years in OB. I didn't say 36, oh, 22.
Last time we said 36. I've been nurse for 36 years.
So Mary Volsky, who's a nurse manager for OB at our hospital. We've got Lori Tonoli here, and we've got, oh no, Chris is not here, but we have Lori Tonoli here, who's a nurse practitioner at Caring Center for Women. We've got Jane Unsicker, who's here from CareNet, nurse practitioner as well. Megan McFall, who runs our Indian River County Healthy Start. And we have a couple of our trustees here tonight. I'd like to recognize as well. We have Michael Kent sitting over here, and we have Paul Westcott back here. So thank you for being here. So they work very hard in a elected, unpaid official role sitting on the Board of Trustees for the district for 4 years, doing things just like this, making sure that we have access to affordable health care, not just for the wealthy, but for everyone in our county. So on the way in, next to the snacks, we had a survey which you picked up. You see on the front, there's a QR code. If you scan the QR code with your phone, so we also had paper copies just in case we had folks attend who don't have a phone, so you can fill out the paper copy. We have pens over there. But feel free to scan the QR code and complete the survey. We're collecting all this data from last night, tonight, and tomorrow, in addition to the survey, the countywide survey. And this data will be presented to our Board of Trustees next Wednesday. And we'll be talking about, moving forward with maternity at that point. For the folks on Zoom, they have the same option where there's a QR code, they can get on there and scan, and they can complete the survey as well. And it's really important. The whole goal of this is to hear what the community thinks about these two questions. Do you want labor and delivery services close to home in Indian River County? Number two, do you feel comfortable with the hospital district spending tax dollars to make sure that we can have this program be affordable for the next year? Now, over the next year, what we would do is we would work with the hospital and all our other community partners. And we would try to figure out a long-term solution for sustainability. So that's what the next year would look like. Questions or comments, you could ask either one. But you could, just if you want to raise your hand to speak, we'll come around and get to you. Same with the folks online. They can post their comments or questions, and we will get to them as well. Okay. We're going to limit the questions and comments to a minute at first. Not sure how much time we'll have. We made it through last night. It's a smaller group, but not sure. We just want to make sure we give everyone a chance to be heard. Okay, so again, thank you for the time and effort to come here first week of school, and it's dinner time, so just thanks for coming. Your voice is very important to the district and our trustees in helping make our decision. So thank you. So let's get started. First question or comment? Yes, ma'am.
Back when you were setting up programs and you were setting up partners with different programs at the hospital, we did surveys on the women to find out why they weren't coming for prenatal care. We wanted to know what the reasons were. We then set out with the hospital district to meet those needs. We were very successful. I think they set a good program of partners with prenatal care, good outcome. But I'm wondering what we're doing to try and attract the people that have left. I mean, there are people that are, a number of people are going home first, and that's okay, that's a choice. But we're losing to other hospitals. I mean, they're going up to Melbourne to deliver, they're going down to Port St. Lucie, and the nurses do the same thing. They don't get a lot of births here that the hospitals do. Are they gonna do some research on what the needs are and what women really want? That would bring them in and help with the hospital.
As far as women or as far as OBs delivering?
Well, you can answer the OBs, but I want to know what the women want. They're the ones that are leaving.
Yeah.
The ones that are going where the OBs are.
Indeed. Who would like to take that?
Okay. Right.
I could hear most of what she said. It may be helpful as we go through the deliberation for you just to briefly restate.
Okay, sure, happy to. So thanks for the question, Jenny. So the question was, if we have women giving birth, leaving for other hospitals, what's the reason for that?
So
What do they say?
I think that is a really amazing idea to look at in that sustainability plan after this part. What I can tell you from my perspective is that one of the things that has been talked about is that Cleveland's, that our hospitals is still exactly what it looked like in 1990s. And I frequently joke that, the 1990s are knocking and they want their stuff back. And the hospital, along with the generous donations of our community, we are in the middle of a $7 million remodel. And the rooms are, I could show you them on my phone, they are gorgeous, gorgeous. So we already have completed 5 of those rooms. And now labor and delivery is completely being re-gutted, or not re-gutted, gutted and redone, including our own personal OR suite.
To your point, you know, so for Healthy Start, when we started to notice that there was a migration outside of Indian River County, we started doing focus groups, and we did focus groups on 3 subset of individuals, you know, 10 women who chose to go outside of our county for prenatal care, 10 women who delivered outside of our county, and then 10 who did both. And we were able to give that information to the leaders at Cleveland Clinic Indian River Hospital in regards to why those women were making those choices. It was multifactorial. Some of it was the mom saying, well, I went because I wanted a NICU. And so when I gave the facts to these moms, which was, did you know that if you got regular, consistent prenatal care, and your provider deemed you not necessary to deliver at a level 2 facility, did you know that the transfer rate of infants delivered at Cleveland Clinic Indian River Hospital was less than 2%? Would you have made a different decision to maybe deliver in your backyard and in your county? And they said, well, yes, but I didn't know that information. Some of it being, well, we don't deliver, no, there aren't VBACs offered. And so some of that all of that information was provided to the leaders at Cleveland Clinic and New River Hospital, and that was back in November of last year. And most recently, we've been having a lot of discussion, and I just talked to Dr. Rothman in the last week, and I'm really happy to say that they're capturing 70 to 80% of the deliveries in Indian River County, which is much different than what it was even a year ago. So what that shows to me is that the information that was provided from those focus groups is that the leaders at Cleveland Clinic listened, are making changes, and they need some time. I say we, because I was a part of that group for so many years, but need some time to make some changes. And when we embarked on this capital campaign pre-COVID, which was going out into the community, asking for philanthropic dollars to go ahead and renovate the unit of labor and delivery and the postpartum unit, is because we knew that there hadn't been renovations done, and that the competing hospitals outside of Indian River County were doing it. Lawnwood was doing a renovation, Holmes was doing a renovation, St. Lucie Medical, and we knew that we needed to go ahead and compete, or else we were going to lose that. Unfortunately, COVID came, and we weren't able to go ahead and do those renovations here in Indian River County, and that is now being done. And so I think that the buzz in regards to the renovation has helped capture some of those moms back, and hopefully.
There's been a lot of positive feedback from the patients about how lovely the rooms are, and I can tell you on a level, and pretty much all of my nurses that are here, we have been busy. We're anticipating close to 900 deliveries this year. And in the last 6 weeks, it's been hopping.
Well, thank you both. Next question, comment?
Well,
Yes, sir.
my name is Peter Heidelman, I'm here with Sebastian. Made a terrible mistake when we had our first pregnancy, in that my wife was carrying twins. And that's not a mistake, but while she was in labor, I let her hold my hand. And I was almost in much pain as she was. Almost. God gives women amazing strength. Almost. Here's the thing. If the issue was, can we afford to have emergency rooms in the hospital, we would be discussing it. Of course, you have to have emergency rooms. And when women are in labor, driving a half an hour, 45 minutes further away in order to get help, to me, it's just an untenable situation. And so basically making a comment on it from my perspective. I would also say that if there's a committee somewhere who's going to make that decision, I would hope they pass a state law that any of the men on that committee, if they want to go to the bathroom, they have to go to Melbourne or St. Lucie to go to the bathroom. By state law, so they can suffer a little bit from it.
Oh, Peter, appreciate the comment, and said with such a straight face. Yeah,
Great humor.
thank you, sir.
To expand on what she was saying, if you're trying to track more women, we have the capability to handle more pregnancies there. If they do get 95% of that, we will be more profitable just for them. Is it just gonna create a more of a deficit? Because are they profitable? If they're already 7 million in, just bring more, that can make it more work.
It would depend, and I'll just, I spent 30 years in healthcare operations, so it would depend on never maternity, but it would depend on the type of insurance they have, quite honestly. That's a big part of this, is, when you have folks with, Florida Blue, great PPO plans, and then some of the better payers, if those folks are not at our hospital, that's a problem. Because ultimately, if you had more volume and it was the right volume, and, we get above our, critical threshold of 1,000, 1,200, or whatever that would be, and you have the right payers in there, will it make a difference to the bottom line? Oh, yeah, of course. Yeah, but I'm not certain, I don't have the data, so I can't state that the percentage of folks who are leaving for other hospitals have different insurance, I don't know. Yeah. But thank you, that's a good question. Yes, ma'am.
So I'm trying to understand, at some point, I think we need private islands, we needed private insured patients to deliver at our hospital in order to be profitable. And when you first introduced yourself, you were talking about how we're gonna make all of the residents in this county be able to afford great healthcare, even those that don't have a lot of money. And how far does like Healthy Start go? I thought they did something about helping women fill out, maybe it was college, applications or something, because we want the community to be employed, to get private healthcare through their employers, so that they can make
So-
us money.
Healthy Start doesn't, so Healthy Start, we sit down with moms who are not insured to do PEPW which is a presumptive eligibility for pregnant women. So if they are not insured, we try to get them, Medicaid insurance. So that way they have some type of coverage. And what that does is that gives them 45-day emergency Medicaid while they're attempting to get the full Medicaid. So we do help with that, but that doesn't guarantee that the mom is going to qualify for full Medicaid.
But I think one of your points is thinking, I think one of your points is something that, I've talked about with the county, is just the fact that if Indian River County is going to grow jobs, grow business, grow the economy, we need industries down here. We need employers besides, the sheriff's office, school district, Piper, the hospital. Those are all our biggest companies. Publix might be in there somewhere with the most employees. But we need more of those types of organizations, and we need tech. We need all sorts of businesses that are gonna generate high-paying jobs that have multiple insurance offerings that are a Florida Blue PPO. And for our county, we don't have the number of businesses. I mean, look at the ages in our county. I mean, it's,
Going up.
we slant older. And, there's all kinds of downstream effects of, and I'm not saying we're not welcoming to families, but if you look at where the population is going, if we want an environment where we want to welcome families, it's not just a hospital district solution. It's not a hospital solution. It's a county-wide. We all have to want that. We have to decide what we want to be. And I dare say, because I've only been here 2 years, and I'm from New York, so this is, I love it here, but there's opportunities for us to grow businesses in here. We have the whole west part of the county, data centers, IT, like there's so much opportunity, and I don't understand, why we don't go after that. High-paying jobs, you'll have kids and your kids will stay. Your grandkids will want to come back into town. Anyhow, my soapbox, give me another one.
I do wanna mention though, that even if we had So first of all, births in Indian River County have been flat of about 1,200 per of residents for 20+ years. We haven't really moved the needle in regards to really going over 1,250 in 20+ years. Number two, so I don't really see that changing in any, in the near foreseeable future, especially if we are states where we're at from a growth perspective. Number two, even if we captured all 1,200 deliveries in Indian River County, and 40% of those were insured patients, the reimbursement rate, even on insured, even on your best PPO rate, is extremely, extremely low, very low. Dr. Crawford said it best yesterday, and I will quickly quote her. For a global, so that is all 13 prenatal visits. This is the delivery, and then including your 2 postpartum visits for a vaginal delivery, you're getting reimbursed for a good PPO rate at $2,600. For a cesarean section rate, you're getting reimbursed at $3,100. So even if you're capturing all of those insured patients, OB is always going to be a mission-driven service line.
You're talking about the provider,
Yes,
not what the hospitals do.
right.
And that's not unique to us, that's nationwide.
Nationwide,
The
correct.
reason for the closures, it's not just towns that have very high Medicaid parents,
Right.
but it's all over the country, regardless of where.
Labor delivery is a lot like philosophy.
It is.
So you think that way. And, but now I'll be quiet, so I really want to hear from you all, but Frank, the patient base, 75% of the completed place patient base is Medicare or Medicaid or uninsured. That is a horrible patient mix,
Yes.
mix. And to Frank's point, our communities decide, my kids are grown. 2 of them are out of county because limited opportunities and, we need to decide what we want to have here. We want to have those opportunities to grow the better jobs, grow a middle class. That's an undercurrent that hasn't been discussed, but it's a big part of this. Thank you. I'm sorry for.
Thank you.
We do have a Zoom question.
Okay.
Lisa Geiser asks, how many moms choose other hospitals because of NICUs? Does Cleveland Clinic Indian River plan to add a NICU?
So, I don't actually have the complete data of what that is. I think, Megan, when you did your, community look at that, was it about 30% or 20 to 30% that chose to go elsewhere for? 36%. Okay.
Thank you, there you go. Thank you all.
That chose for a level 2.
So just to be clear, so 36% leave for level of care, for a higher level of
For
care.
the choice for a higher level of care.
Choice for higher.
That as far as plans for a level 2 NICU or another, that would be part of that conversation that we have after this of what would help us become sustainable. And sustainable means like breaking even, right? So that, I think that word that's too preemptive of a question to be able to answer. But I wanted to kind of tag on to what trustee Westcott said. That our community, right, how important this is in our community. You said 75% of patients are either uninsured or have Medicaid. Those patients are the ones, there was a wonderful woman here yesterday at the other one, and she said that we are one of the richest counties in the world, actually, and definitely in the United States. And I reminded that we are also, while we have all that money, or some people have all that money, we have women and families that don't know where their next meal is coming from. They're living on dirt floors. They don't have hot water. I don't know about you, but I can't get in the shower if it's not hot water. That we have both ends of the spectrum and how important it is for them to have the care that they need. Those are vulnerable. That's what we'll have this conversation, what's gonna happen to it.
Thank you.
How are they gonna drive the extra 30 minutes? So that they'll be-
They won't, they'll be calling 911 and they'll be using our EMS system.
It's a good question.
Now, one of the-
How many of those babies will be delivered on the road because they can't get there in time?
And babies are, animals.
Yeah, placental abruptions. If they rush them to Cleveland Clinic because that's the nearest hospital, they better get there. Who's gonna deliver them? It's not gonna be anyone to do it. Right, so those babies are gonna
Well,
die.
that's one of the problems I mentioned last night, is the fact that even if you put distance aside, 30 minutes, 45 minutes, or 30 minutes, and 15, 20 minutes to 60 minutes. We have 900 babies that have to be delivered. You can't just take 900 babies and send them to Longwood, 900 and send them to homes, 450. They don't have the capacity for that. So I mean, so this is, it's a lot more than just even the driving distance. We don't have the resources. So that's a concern, but let me get you.
I'm Kim Baldwin, I'm one of the midwives that represent Women's Health. So I'm just gonna tag off of them. My two concerns are, of course, fetal and maternal mortality because of the transport, the distance, and all the examples that they gave. And secondly, what kind of taxing is that gonna put on our emergency rooms and our EMS systems? Because when someone truly needs an ambulance or almost having a heart attack, who's gonna come up when EMS is 30 minutes away? And my son-in-law's firefighter, and he said a transport going, 2 hours away, it's 2 hours to get that ambulance back in our county, even if they rush to get there. So that's tying off one of our ambulances, or, you never know, but I think it's more of a local county problem than
It is.
just saying that
It
we're
is.
just gonna put a lot of taxing on other areas than just not pay.
It is, and again, we're early in the conversation, we're working with the hospital and our other community partners, our stakeholders. To try to figure out how to solve this, and a big part of this is how you all feel. I really encourage you, in addition to thank you for being here, but please complete the surveys, because we're gonna use all that data, we appreciate it. Please.
So, my name is Alana, and I just wanna say, like, coming back to the community, I was a very young mom, this is my daughter here, Kim delivered her. Delivered my other one, and I know Lori, Nathan's given the opportunity, ample opportunity, I have now a career with Healthy Start, being able to work beside some women who met me at 17 years old when I felt like I couldn't do anything, and I had nobody, they talked me up. She brought me over for dinner, when she knew that I didn't have much, after I came home with her. So now I'm working beside these women, and I'm working with the women and their mothers in the community, and I don't think that it's fair for them to have to travel elsewhere. I've gone to other hospitals, I've gone to homes, I've gone down to Longwood, and they are capped. I've in triage, women are, like, it just wouldn't make sense for them to leave this area. This area has a great support system. I have a story for that, I can back that up. And, I just wanted to say, like, thank you for the opportunity that I've given me in a career to help other women. There are women who really, they need this, and I know we have a broad, like, I don't know how to say it the right way, because I didn't have to say much, but,
Sorry.
a lot of Medicaid women, young women, including myself, I'm woman right now. I have a career, I'm able to afford my own private Blue Cross Blue Shield plan and give back. And it's just, and I was just a young mom going through those years. So, how many other women can we help with that? And how many other families? I mean, look at. Without the program, without the people in the community, but this is the way that the nurses look at you, like, you're gonna be okay, you got this, the confidence, the strength, everything behind it, it's meant everything to me, and I really think it would be a horrible idea to take this away from our community. Really do.
Thank you, thank you.
To her point, with Healthy Start, we have the opportunity to have face-to-face interaction and conversation because we have the privilege of being at Partners in Women's Health. We have the privilege of being at a caring center for women. We have the privilege of being on the postpartum unit. And you take that infrastructure away, and we're gonna be cold calling women on the phone asking, can we get to you? Can we help you? Can we provide you a doula? Do you need help with lactation? And talk about outcomes. You know, if you wanna see what a maternity desert looks like, pull up Florida charts. Go and look at Okeechobee County, which has been a maternity desert for 20+ years, and you will see them in the red year after year after year after year, which shows you that they have one of the worst outcomes in the state of Florida, not because of choice, but because they don't have a choice. They don't have a delivering hospital.
There's one thing that you have to remember, I think it's the underlying everything, is that the quality of the healthcare in the community is usually gauged by how you treat your women and children. We really need that all this time. We can't afford not to.
That's very true. Like on a personal note, my husband had his urology surgery at Cleveland Clinic in River Hospital because I told him to have the surgery, right? Because that's where the doctor was. It was good for him. And I worked there. I made that decision for him. And we as women frequently encourage our husbands to make the right decisions.
Becker's Healthcare will tell you, there's an article, there's statistics that 80% of households, the medical decisions are made by the women. And the ones that are not made by the women are because it's physician-led men that are in the house, in the homes. So, and most of the women, those decisions are made because as an adult, the first time that they have comprehensive medical care is when they've had a child. So if they have good care, they're gonna go ahead and bring their families back to that organization. So really, if we take it away, you're compromising all programs within the hospital setting, if you think about it.
Thank you. We just have a question. I will get to you. We have a question online.
Yeah, there's a comment by Irene Ives. She mentions, I would like to say my concern would be mom's mental health and their care and resources being taken away. Healthy Start has been amazing with having the resources and lactation care that moms so desperately need. There's one more.
Please.
Brianna W says, not a question from another doula from Healthy Start here. Completely agree with Alana. The families need Healthy Start. The moms I've helped have said they could not have done pregnancy without Healthy Start and all the programs. They are so glad they found it. It's insane to possibly take away such a great helping hospital.
Thank you.
Well, and I just wanted to back Alana up on one of the things that Healthy Start does. I am Autumn Schneider from Healthy Start, but one of the things that we really incorporated, and we're talking about community, is we have incorporated workforce development in our programs. We have, through our partnerships with Hospital District and Cleveland Clinic, we have added, we gave out 18 scholarships to certify additional lactation counselors to be able to be on board and in the community reaching moms. We provide doula scholarships and the training to pay for that, which then again gives back to the community. What Mona said, there's all of these opportunities and all of that is through the partnership here. And on that note, because we are talking about moms, which different moms, but I want to throw out the dads too. Because through these opportunities and the relationships that we have built, we now have offered one of our dads who graduated our program a job at Healthy Start, now giving back to dads. So it is a trickle down effect, and it affects the entire community in that way. And taking that away, as Megan said, cold calling, we lose that face to face and the relationship that we have and are able to build with the trust in partnership with the hospital and access of families. Our goal is ongoing change. We are changing generation. We are creating generational change so that our percentages move from a 50-50 Medicaid split to a 25-75, where we have more families who have access to health insurance and better benefits through that health insurance. And of course, then comes reform, but I'll stop there.
Thank you very much, sir.
So I'm a health insurance agent.
I work for the board of them.
Well, welcome.
I mean, the best point I've heard is what you said, bringing, careers into the area, because most people in this area, they work for a small business, they're not offered health insurance. Small businesses don't have to offer health insurance, and large corporations do. So it leaves all these people having to buy privately through the marketplace, the Affordable Care Act. And what ends up happening is, when you're pregnant, you automatically qualify for Medicaid. You're not supposed to have the ACA and Medicaid at the same time, you're taking them off the ACA. So when you're looking at, oh, all these women have Medicaid, that's why. And, you know, it's not gonna get better if you don't very important jobs in the area. However, you know, the statistic you need to be looking at is, are we willing to take a loss in labor and delivery in order to profit in other areas in the hospital? Because like you're saying, you know, people are being born here, this is where women are comfortable, they're gonna bring themselves back to this hospital for other care.
Wonderful points. Thank you very much. Thank you.
I would like to say something real quick.
Please.
For starters, my name is Lori Tonioli, and I work with Carissa Wright and Laura Reed, and we are honored to be able to work for a caring center for women. And from January to July, we provided care for pregnant women for, I think it was a little over 1,200 patients. Also did some wellness visits for 530 some odd women. We have a close relationship with Healthy Start and Alana talking about community. These women, they need us. These 1,200 of these women that we've seen, a lot of them are returning to partners. They've delivered with partners before. Some of the reasons why they might want to deliver other places, it kind of shocks me sometimes. It's just the look of the unit or some fluff, you know, really, sometimes it's not something so serious as wanting a NICU. So I think what they are doing now and working together with us, having numbers that I can now show these women, you know, I want to show you what good hands you are in. We can make a huge difference and build this community up and keep labor very open. It is very, very important.
Thank you.
Something I think is really cool is all four of the women sitting up here, we all have relationships, including my director, right? So we all, something happens on the Healthy Start end that they have a concern about patients, they are calling us and we're prepping. Same thing with Caring Place for Women, and we're supporting each other to ensure that every woman in our community has one. That's partners, that's each of us, and all of our people that work with us.
Thank you, Mary. Any other questions, comments? Group? Yes, ma'am.
What are the chances of being able, I know we're in a deficit, but of being able to have an intensive care, you know, legal unit? Obviously the renovation is necessary, but it probably is the bottom line here, so. Has it ever been discussed? Has it ever been proposed?
Thank you for the question. I won't speak on behalf of Cleveland Clinic, but I will say, and Mary mentioned that a couple minutes earlier. I think that's that would be part of the discussion over the next several months as part of the sustainability. Understanding the reasons why folks are leaving the county, understand if it's actually for a higher level of care, is it perception of higher level of care? But to get an understanding of all of that as part of the grand decision over the next 12 months. Is this something that we want to reimagine and perhaps look differently? Maybe we can, as great as the care is now, perhaps there's a way that we can structure it. We could maybe do it at lower costs, and look at some alternative care models. And or maybe raise the level of care. So that would all be part of the discussion over the next several months. Thank you. Anyone else, questions or comments?
One last question, if we were to have, was it 1,700 deliveries in our county? 1,200 deliveries in our county, if they were all privately insured, even C-section, 100% rather than like 30% national average, we're still gonna be, what is that, 3.5 million, are we gonna break even?
I don't know what they,
Or, no.
Yeah. I can't speak, I can't speak, I don't think there's ever a chance that our county is gonna be all private.
So so the question is, do we take the loss and supplement that income with taxes, increase taxes?
Well, and that's what we're trying to get to.
Yeah.
The question, as trustee Westcott said, this is a loss leader everywhere. This is not any hospital that's making tens of millions of dollars anywhere in the, so, but yeah, it's, we need some time to, figure out how to solve this. And I mean, this is a complex issue. That's why we're, and we're asking what you think. It's a very complex issue. And as much as we know about maternity deserts, we know there are some unintended consequences we haven't discussed. In addition to EMS, and longer response times for other conditions, additional costs that would be, that would impact our county related to EMS, and the additional work that they're doing. Downstream things, how it's gonna affect jobs, economy, all that, bringing young folks here, recruitment, retention of healthcare providers. There's a whole long list, but there's still probably about 10 things that we haven't mentioned, we don't know. So, anyway.
I think I said something really important earlier, which is that upset labor and delivery, that is mission driven. People go into that, not because they wanna make bank, but because they love what they do and they wanna make a difference in the individual's life. So like I was showing somebody a picture of a baby that now I hold near and dear to my heart. We are driven because we care about the individuals. And to continue that moving forward is what we're really talking about. We know it's never going to be the like.
Thank you, Martha. Please.
Maybe this was discussed earlier,
It's okay, just say it again.
why is this a concern now? Like, why hasn't it been a concern in the past? How have we been getting mild years? Like, I've never heard conversation like this happen before, so I'm just wondering what has changed?
Yeah, well, this is a growing trend. And, as we look ahead, so, the hospital district, the agreement we have with our hospital is for them to provide certain services over a certain 10-year time, over a 10-year time period. We're 3.5 years out from that time period. December 31st of 2028, we would have to develop we have to develop some new agreements, but I would say that I don't know how long it's gonna take us to solve this. It makes sense to say, okay, 3.5 years out, given the trends we're seeing, let's have a discussion now, just to give us enough time. The birth rates across the nation are not increasing, the shortages of OBs are not getting any better. The challenges are compounding, cost of everything, supply costs are going up, labor costs, everything's going up. So it's a good time to talk about it, and that's again a function of the district is, let's get ahead of any of these issues. Trustees feel it's an important responsibility of ours to get ahead of any issues before they become issues. So I know we're early in this, but it's an important discussion to have now. Yes, ma'am. Ma'am, I wasn't, so I will say. No, it was not just maternity, so I can't speak, I can speak to some of the detail around that, but I can't speak to the negotiation. I wasn't here for that, and that was done prior to COVID, but there's several services, that need to stay open for 10 years. Maternity happens to be one of those services. The other services are GI, cardiology, they're not oncology services, they're not services that, I would anticipate any hospital will close. And we're not seeing trends in hospitals closing those services. But that's not the case for maternity. We're seeing that happen. So that's why we're having the maternity discussion. Sir?
I've been in sales and I understand marketing. Put out a loss leader who hopefully they'll come and hit the store to buy some other stuff. Are there other departments of the hospital that are making considerable profits? That could be then transferred or whatever to help offset some of this loss that you're supposed to take.
Your question makes sense. I can't answer the question. I won't on behalf of, I don't speak for the hospital, but I think your point goes back to a comment that Megan said. And that point was because, you know, the maternity could be seen as the entryway. Maternity leads to pediatrics, leads to women are making healthcare decisions 80% of the time. You know, you need your husband to go for a colonoscopy, you need, so it's not just the maternity is the beginning of the journey. And so there's a lot of downstream business to profitable services that where hospitals generate revenue, and it starts at maternity. The concern Megan mentioned is if we don't have maternity, and if women aren't drawn to the hospital could potentially lose revenue from all these profitable services, to your point, man. So.
Somebody
Yeah.
yesterday said, and I thought it was a very good comment, is if we don't have maternity or labor and delivery, are those educated, coming out of college, young women going to want to come here to work to be teachers or doctors or other professionals? Are they gonna want to come to a place where they're gonna have to drive 45 minutes to have a baby? And there was a lovely young lady that said how important that was to her yesterday, just sitting right about where you are, Victoria. And how that was part of the decision making. She's getting to the point where she wants to have children and support them. I thought that was a very poignant comment yesterday. And then on a slightly other side note, you know, that maternity desert, I don't know if we really understand what a maternity desert is. But it is an area, a county or a larger area that does not provide maternity services to people in that area. Nurse Blake, if you have watched, he has a little spoof comment that talks about it. But it is a real problem in the United States. There are areas and multi-counties in different states in the United States that women don't have the access to care. It's, to me, it's a fundamental, it's just like the hierarchy of things, right? It's one of those fundamental things that to be there for all of us.
Any other?
I do, by signing in with our email and name, will that get us on a list to find out more future topics, more meetings?
We haven't gotten that far, but I guess we could say yes. You know, the folks everyone who left their emails last night, Shannon sent an email to today. Encouraging folks to complete the survey so we can collect the data, but there's no reason we can't use it for the purpose that you just mentioned. So it's a good idea, thank you.
I'm interested.
Sure. Well, you'll hear about it. One way or another.
Sorry, an article today.
There's just a great comment on Zoom. Shanti said, thank you for holding these sessions. It's essential to have these services in our community for so many reasons. Thank you, Shanti.
So any other questions from anyone, any other comments? And that's okay if
Let
not,
me make another comment.
please.
Our department is not just supporting our department. When we all go, what happens to the ER that has pediatric patients that come in that are coding? That they struggle with, these little ones, their IV sites that they can't get. Who are they gonna have to come down and give them the support that they need to get these things?
Because right now, all the nurses work.
It's you guys.
Yeah, because they don't know what to do with a 3 week that comes in and they've gotta get this teeny tiny little IV in.
Or a 3-month-old, or what happens with the home deliveries
Right,
that on bad,
that go bad.
right?
Well, this is the complexity of the discussion. This is the complexity of the issues. So I'm glad you're bringing those points up. Thank you. Mr. Ken?
I'm not supposed to talk.
Yes, sure you can talk.
Last night and tonight, my observation is the discussions have been wonderful and appropriate. People are trying to figure out what the issue is, and there are different aspects that we don't have answers to, because we're asking about them. So it's just getting informed. There were 2 questions we wanted answers to. My opinion is, based on what I heard tonight, what I heard last night, you know, the 100+ people in the room, was the vast majority appeared to say yes to. We should be able to offer these services in this community. But nobody specifically tonight, and not that many last night, actually answered the second question, which is a financial. Should your tax dollars levied by the hospital district be utilized in this way? I mean, we're involved, in this. We helped establish. Partners in women's health, 30 whatever years, was a hospital district initiative that became a part of the labor agreement. But this is new. And it's different, and there are a lot of people in this community, who are very fiscally conscious. I'm gonna ask our executive director to share the data, which I haven't shared, but I trust, right? What the cost would be, and this is gonna be an average cost based, and again, this name is not sales tax, this is ad valorem tax, this is tax against your property, those that own them. And the average cost is based on the average cost of a home, which I'm guessing probably somewhere $50,000. I don't even know.
Yeah,
But share the data that you have and see if anybody wants to answer the
thank
question.
you, Michael. So the calculation I did, I had mentioned this number last night. And it was published in TC Pom today. The average cost of a house in our county in May of 2025, when I initially looked at this calculation, was $380,000. So I know it's higher than you expected, Mike. So when I look at the amount of taxes we levy based on our current millage rate, okay? And then I look at the incremental 3.5 million on top of that, it's about 14% of the total amount we would levy. And just to simplify it, comes out to about $41.50 per household, or $42, as I said last night. So the incremental cost to add 3.5 million on would be $42 per household.
Per year.
Per year.
Per year.
Free. But before, sir, I will get you, we have a question online.
Just a comment from Zoom, an anonymous Zoom participant stated that they used to work at Partners. And when helping mothers make appointments, they would receive some calls from moms calling ahead of time, making sure there was a hospital nearby before moving to the area. Whether it was at the start of their pregnancy or transferring midway, having a labor and delivery and these services will help our community grow by attracting younger people who are starting families.
Thank you, sir.
So $42 a year would be for the first year. And what we fear is it goes up and up and up and up every year after that. That's as a taxpayer, that's retiring. That's a common. The other thing I asked about partners in the hospital who make some money. And of course, we all complain about CEOs that pay too much money. You gotta hire talent for the hospital. I just had some bursitis. I went to that new orthopedic surgery center around the corner from you at A1A. They didn't ask me for any money. They're a beautiful building. They don't seem to be hurting. So I'm wondering about cutting corners, wondering about cost savings in the building. Talking about some of the higher paid people and what their salaries are. Now, granted, if I'm gonna have a heart surgery, I was the best paid surgeon they had, probably the best, but maybe not necessarily so. My question is, what about cost cutting issues? Have they been faced? Have they been looked at seriously to see whether there are some savings within the organization right now that could help mitigate this extra cost? Because once you put something on an ad valorem thing, it's a tax. It doesn't sound like a tax, but it's a tax. You put it on a pig, it's so big. So it's gonna be a tax. And as we know from our experience, a small tax never goes away and almost always goes up.
So great points, and I'm gonna answer what I can, not representing Cleveland Clinic. So to your first point, orthopedic surgery, if you look at the top compensation for all physicians and surgeons across the country, okay? First, highest paid on average, neurosurgery. Second, orthopedics. So, I mean, orthopedics is a completely different world, completely different structure. It is not maternity, all right? Second thing is when it comes to cost cutting. The hospital 2 years ago reported losses of over $60 million. They have been in an aggressive aggressively trying to reduce those costs. Last year, they were reported losses of 40-something million. This year, they're on track to decrease those losses even further. And they're working very hard to do that. Now, this is what I'm being told. I have no operational responsibility or role within the hospital. This is what I'm being told, and this is what the numbers I see tell me. So I'm pretty sure that they're gonna get their budget neutral for the hospital, and understand, like any business, you can't operate losing 60, 40, $30 million every year. So they're in the process of turning the hospital around, so to speak. They came here, COVID happened. Payer mix was what it was, they didn't exactly get off to a great start, no hospital would. Our community hospital, if Cleveland wasn't, any hospital struggles, is gonna struggle through that. So there's that, and I had a third point, but I'm trying to remember what it was.
So I think it was at $42 1 year, but it's gonna be.
Oh, yes, okay, that's it. So my point was gonna be correct, so over the next 12 months, we would take the time, a big part of this is the financial piece, so, because it's not gonna be acceptable to say, okay, it's $42 now, but next year, maybe it's $42.50. Okay, but next year it can't be $84, okay? So there would have to be some control on how much those costs are gonna escalate that would be acceptable. That would be part of the discussion between our board of trustees and of course, hospital leadership in this process. So we have to really get a good understanding of what those costs are. We're just looking at, to Mr. Kin's point, the first point is to say, do we want these services? What I'm hearing a lot of people say is yes. Number two is, would we want to use tax dollars for it? And we may get a resounding or 50% of people say yes at $42, but I'm sure in people's minds, there's as long as that doesn't go to, $420 for the year. And again, I'm using extreme examples just to make a point. That would be part of the discussion. We can't be in a situation where the cost would escalate 20% year over year. That wouldn't make any sense. That's not sustainable. The plan we're talking about getting to over the next 12 months, sustainability, and not just clinical sustainability, financial sustainability, or we won't have clinical sustainability.
And I would just comment on that, I'm a very trusting person, but on the cynical side, that comes into play. When 30, 40 years ago, states started doing the lottery, they said, let's do a lottery and we can reduce or eliminate the property tax. And the politicians said, oh, look at all this extra money we had. And there's not one state that has permanently reduced property tax at all. All the states that do the lottery. I'm concerned that bureaucrats like politicians say, gee, look at all this extra money. We don't have to work as hard, save money. So if there's gonna be an ad valorem thing, I want a sunset clause. That says that so many days you're done, so many years are done. If you've done the homework, that's your problem, not mine.
Fair enough. I appreciate that comment. Yes, please.
There's a question on Zoom from Heather. She says, it seems to me that not having the basic service of labor and delivery in the community we live in would stunt an otherwise thriving community. What's the city's stance on this matter?
Thank you for the question. I can't speak for the city. If you were, ma'am, if you were on the call, earlier, you did hear me say that I would love to see growth in jobs and high-paying jobs, especially in tech in our county. That would, I think, help us a lot in a lot of different ways, but I have no role, political or otherwise, to be able to change any of that. So I'm focusing on controlling what we can and making a difference where we can. So thank you for the question.
What do other counties do?
Well, every county
It's
structure.
sort of like taxes, I guess.
And also, even we're an independent special district, the hospital district is an independent special district, so we don't report to our, we're responsible for the health and well-being of our county. We don't report to our county. We're accountable to Tallahassee, the state. So special districts, there are special districts that are dependent, that are working directly with the county. There are some counties where they pay for the entire hospital, healthcare, everything. We're a small county. You look at healthcare district in Palm Beach County and counties that are just completely different. There's such variability in structures. again, if we had more businesses here, more tax base, more, every, decisions get easier when you've got jobs and more money coming in. But it's variable, it's variable. So, we have time for maybe one more question. You have one? Question or comment? Or who didn't say anything? Did you say anything, Dan? Do you have anything? Would you be our closing? All right, we got a stage here. Let's end it. If you have any closing, is there anything you want to share before I make a closing bill? You don't
I
have to.
think everything's been said.
Okay, all right, fair enough. A lot of it has. Mary, go ahead.
So I was born and raised in Petersburg. I was born in the old hospital, that has since been torn down because it was the old. It's still old. No, something, I had the tonsils taken out in the hospital. I did my clinicals as a nurse in a hospital. My mom had her deliveries, all three of her deliveries in the hospital had a restrict in the hospital. The hospital is important to me, and this community is important to me. When I was a senior in high school, I remember all the high school students, and we used to call this Zero Beach, right? Remember that? And everybody wanted to leave, and this community is so different than it was back in 1984. When I graduated from high school. It is huge compared, and I want to see it to continue to grow. The only thing in my entire life I ever really wanted was to be a mother. And it's the one thing I never was able to do. So every day I spend all my effort, including neglecting my husband a little bit, and making sure all women have their needs met when they have babies, and I hope we all the other.
Thank you for sharing that story. So everyone, thank you so much for being here. Thank you so much for everyone joining us online. Please take the time to fill out the survey. Our trustees are really counting on your feedback. Zeroes in some more on the questions that trustee Kent mentioned earlier. The main questions being, do you want maternity services close to home in our county? And are you okay with the using tax dollars through the hospital district to pay for these services? And this is not indefinitely, to your point, sir. This would be for the next 12 months, so we can figure out all the details, all the parameters, and what we would want this to look like. This is a community conversation. This isn't us carte blanche going in this direction and saying, yeah, we'll tell you about the taxes someday. The community is going to be involved in this. We're doing this because we need to hear your voices. And that will continue as part of this discussion over the next 12 months, if we do move forward with support. So thank you so much for being here. I appreciate it. Thank you.